Welcome back to The Explainer. Today, we're putting on our medical detective hats to investigate a somewhat hidden yet totally devastating condition known as pancreatic exocrine insufficiency, or PEI for short. We're going to be unpacking the latest, highly comprehensive European clinical guidelines put together by United European Gastroenterology and a massive multidisciplinary group of experts. You see, this isn't just about a single organ struggling to keep up. It's really about a cascading system failure that literally robs the body of its most basic building blocks. Here's our quick roadmap for today. First, understanding PEI, then the symptoms and consequences, how we go about diagnosing the condition, a deep dive into enzyme replacement therapy, and finally, diet and nutrition. Let's just jump right in. All right, part 1, understanding PEI. Have you ever thought about what actually happens when your body's digestive factory just shuts down? I mean, we don't magically absorb the food we eat, right? We absorb macronutrients, and that takes some serious, highly precise enzymatic breakdown. When the pancreas fails to pump out enough enzymes and bicarbonates, this crucial metabolic assembly line basically stalls out. So food passes right through the GI tract, but without the chemical keys needed to actually unlock its vital nutrients. The clinical guidelines officially call this system failure PEI. But what the experts really want to stress here is that this is fundamentally a maldigestion syndrome. It's not just about low enzyme production. It's about those enzymes totally failing to meet the food at the exact right time, in the right place, and in the right environment. For instance, if the pH of the intestine is off, or if the anatomy has been tweaked by a previous upper GI surgery, digestion is going to fail, even if the pancreas itself is perfectly intact. Mapping out the clinical pathway gives us this incredible bird's-eye view of how a localized problem snowballs into severe consequences, and exactly how doctors need to intervene. The logic flows straight down. It all starts with that drop in secretion, which triggers the nasty intestinal symptoms and nutritional deficits. This then forces clinicians into a really specific, multi-step diagnostic process, ultimately leading to highly tailored treatment protocols. It's like a massive puzzle, and seeing how the pieces fit together is exactly what we're unpacking today. Moving on to part 2, symptoms and consequences. And honestly, the fallout from this is pretty severe. It really targets patients who already have high-risk conditions. If someone has cystic fibrosis, chronic pancreatitis, or pancreatic cancer, they are at an incredibly high risk for developing PEI. The consequences are, well, they're devastating. We're talking about symptoms like steatorrhea, which is excess fat in the stool, along with rapid weight loss and crippling nutritional deficiencies. Patients literally lose muscle mass. They can develop osteoporosis because they aren't absorbing fat-soluble vitamins. And overall, they face a massive long-term drop in their quality of life. Which brings us to part 3, diagnosing the condition. So how do medical detectives actually track this down? The symptoms are incredibly nonspecific, and they overlap with a dozen other digestive issues, right? It takes a highly structured, evidence-based approach. The modern workup actually shifts away from just relying on one single imperfect test. Instead, the guidelines demand a 3-step combined assessment to build a rock-solid case. First up, clinicians have to thoroughly evaluate the clinical symptoms. Second, they assess the patient's nutritional status, primarily looking at things like weight loss and muscle mass over time. And third, they run specific pancreatic function tests to confirm the chemical deficit. Now, we really need to bust a common myth right here. Imaging, like an MRI or a CT scan, cannot, I repeat, cannot diagnose PEI itself. A scan is great for showing you a tumor or a visibly damaged pancreas. It shows the underlying structural causes. But it absolutely cannot tell you if the enzymes are actually mixing with the food in the gut. PEI is a functional problem, not just a structural one. You can't just snap a picture of it to prove it's happening. Instead, doctors often lean on non-invasive tools like the FE1 stool test, which zeroes in on a specific enzyme called fecal elastase. It's super widely available, and you only need a small sample. Generally, if the level drops below 200 micrograms per gram, that's a huge red flag. But, and this is a big but, the guidelines explicitly warn that this test has to be interpreted really carefully. It must be done on a formed stool sample, otherwise doctors risk getting false positives. It's an awesome tool, sure, but it's still just one piece of that 3-part diagnostic puzzle. All right, part 4, enzyme replacement therapy. Once we've got a locked-in diagnosis, we move straight to the antidote. And the European guidelines are completely emphatic here. PEI should always be treated. There is literal 100% agreement among the experts on this. Leaving it unchecked isn't just mildly uncomfortable for the patient. It leads to severe, compounding malnutrition, bone disease, and a significantly higher risk of mortality. Treating this is absolutely not optional. It is a life-saving necessity. The gold standard solution for this is pancreatic enzyme replacement therapy, commonly known as PERT. Since the patient's pancreas is basically clocking out, we literally have to supply the enzymes orally. These preparations are mostly porcine-derived, meaning they come from pigs, and they use highly specialized enteric-coated micropellets. This coating is just brilliant pharmacological engineering. It's specifically designed to survive the harsh acidic environment of the stomach and only dissolve once it reaches the more neutral pH of the small intestine. It releases the enzymes exactly where they are needed most. To get things moving, doctors will usually hit it hard with a robust starting dose of roughly 40 to 50,000 units of lipase per main meal, and they'll use about half that amount for snacks. This isn't just some random number they pulled out of a hat. It's carefully calculated to provide roughly 10% of the body's natural physiological output. That 10% is the absolute minimum threshold required to mimic natural digestion and get that metabolic conversion running again. But here's the real kicker. Timing is absolutely everything. You can't just pop these capsules whenever you feel like it. They have to be taken with the meal, and sometimes even staggered throughout the meal. The entire goal is for these synthetic enzymes to perfectly mix with the food, the chyme, as it empties out of the stomach and into the intestine. If those enzymes arrive to the party too early or too late, they completely miss the food, and the therapy just flat out fails. Finally, let's look at part 5, diet and nutrition. Medicine is only half the battle, right? We've got to explore how modern dietary advice fits into this whole puzzle, and we need to clear up a major outdated assumption right now. It used to be this given that if you couldn't digest fat, well, you just had to strictly avoid eating fat. But modern guidelines state the exact opposite. Severely restricting fat can actually make the malnutrition much, much worse. The new standard is to optimize those PERT medication doses so that patients can actually enjoy a normal, varied, and healthy diet. The mindset shift is huge. Fit the medication to the patient's life. Don't restrict the patient's life to fit the disease. Because juggling all this, balancing the fat intake, the micronutrients, the exact enzyme timing, is wildly complex. The guidelines strongly push for bringing in a specialized dietitian. This isn't just a nice-to-have bonus. It's a critical medical intervention. Studies consistently show that patients guided by specialist dietitians have dramatically improved nutritional status, they experience less pain, better fat absorption, and ultimately much higher survival rates. Now, despite all these massive leaps forward in treatment protocols, there are still some pretty vast unmet needs in the field. Experts are quick to point out that we desperately need better epidemiological data, much more refined diagnostic biomarkers, and, critically, new enzyme preparations derived from non-porcine sources for patients who just can't consume animal products. There is still a mountain of research required to really optimize long-term outcomes for everyone. Which leaves us with kind of a provocative question to chew on. As medical science keeps pushing the envelope, how will future breakthroughs finally close these gaps? Will we discover synthetic enzymes that completely replace the porcine models? And how will those advancements further transform the day-to-day lives of people battling this invisible condition? The European guidelines give us an incredible foundation, for sure, but the investigation into optimizing human digestion is clearly far from over. Thanks for joining me on this explainer, and remember to keep questioning the science that shapes our health.